Okay, so let me start by with a bit of context. So this is nothing to do with COVID-19. This is the official ONS registration data on suicide. 2019 registrations recently updated, and what you can see here, here is a rise in suicide in 2018-19. So nothing to do with the pandemic, but a rise in 2018 and 19. Of course, these are registered deaths. So actually the dates of death were earlier. So the 2019 deaths will have occurred in the first half of 2019 only. So there's a bit of an inbuilt delay. Registration deaths at this increase. We're working hard. The Office of National Statistics are working hard in order to try and understand that increase in a bit more detail. They're looking at the stats in a bit more detail. You know, is it something to do with the economy? Is it something to do with services? Is it something to do with media representation? So they're trying to unpick that rise, but I'm sure many of you were aware of that rise in registrations. Apologies, we were a bit stuck there for a while. Here's something else, nothing to do with the pandemic, but it's been published since we last met. So many of you will have heard me bang on about risk assessment in mental health services and how we're all obsessed by it. A couple of weeks ago, we published this paper in Lancet Psychiatry. The link's there on your screens. This was a study led by Jane Graney. And basically what we did was we went to every single mental health service in the country and we said, show us a copy of your suicide risk assessment scale. So we went to all 85 mental health services, and this is what we got back. In some places it was 1 page long, in other places it was 20 pages long, and from 85 mental health services we got back 156 different tools. So quite a lot of different tools. Very varied in their content. In many cases, were designed to kind of try and predict suicide, which we know you can't do. Prediction is extremely difficult. They were designed to kind of inform management, which again we suggest that management isn't formed by a risk score. So a wide variation in practice, a wide variation in the tools. In about a third of areas, the tools were actually things that the services had kind of devised themselves. They weren't even standardized off the peg measures. So big variation in how the tools were used. And clearly, something needs to be done with risk assessment. We actually had a web event on this paper when the paper came out, and it's worth listening to. It's worth listening not because I'm on it, because you've heard everything I have to say, but because of the service user that actually wrote a comment in response to our risk assessment article. Her name is BB. She was otherwise kind of anonymous. And basically, she talked really eloquently about what it was like to be on the receiving end of risk assessments. So, this idea that sometimes risk assessments were used to ration therapy. It wasn't good. And this idea, she said in the event, she said, when I present in crisis, I don't really want my risk assessed. What I want is to be looked after. What I want is kind of high quality care. So this idea that the risk assessment, being on the receiving end of risk assessment, isn't always ideal either. And in terms of the way forward, there's stuff in the paper, there's stuff in our reports, thinking about losing this idea of risk assessment as risk paradigm. That's a bit of a kind of fallacy that we can predict who will and won't take their own life by suicide, but instead focusing on individualized assessments, focusing on high quality management plans, and focusing on maybe giving something to everyone when they present to our services rather than just restricting intervention to high risk people. So the risk assessment paper there for you to look at. The other development, and some of you on the call have been involved in that, is, if you like, the sister project to the suicide prevention quality improvement work. Just for this 6 months, from October to April next year, NHS England have asked NCISH, have asked us to help some of the pilot sites developing community services, community mental health services, as part of the NHS long-term plan, to think about what they might provide in terms of self-harm. So self-harm in the community. So Nick Richards, who helps lead on that work, has helpfully provided a one-page summary of that. So again, it's similar to this program in that we're helping people with the evidence, with measurement, and with implementation. And there's a website there which those of you who haven't seen it might want to have a look at. It contains a few more kind of, if you like, self-harm specific resources. So we're very pleased to be involved in that. That's going to be part of our work going forward. And I know many of you are involved in both the suicide prevention programme and the self-harm one. OK, I can't avoid it any longer. We've got to talk about the pandemic. This you know. So one of the things all of you, is that the pandemic, has had measurable impacts on mental health. So this is just one study from colleagues in Manchester. They've used a standardised measure, the GHQ General Health Questionnaire. They've compared findings in a general population sample in 2018-19 with findings in April 2020, and what you find is a clinically significant increase in distress, about a 10% increase in distress. So mental health has been impacted. What's happened, of course, to suicide and self-harm, and this is the iceberg, and this is making the point, the iceberg of suicidal behaviour, with suicide at the top, self-harm presenting services in the middle, and then the hidden bit under the iceberg, which is self-harm in the community. And I suppose the point with measuring impact of the pandemic on suicidal behaviour is you have to consider each level of the iceberg, otherwise it doesn't really make sense. Top level of the iceberg, suicide, of course, we have to rely on coroners' registrations, ONS, that takes time, so there's a delay, so we don't have good quality real-time data on that nationwide. Here's some data on kids from the National Childcare Mortality Database, where they collate child death overview panel reports. And what they found was that child suicide deaths may have increased in the first bit of lockdown. They were showing around a 40% increase, but actually the numbers were too small for that finding to be statistically significant or to reach any definitive conclusion. So, just a possibility rather than anything definitive. And my understanding is in the data from June to November, there's no increase over and above expected levels of child suicide deaths. But that was the report. And of course, in those young people who tragically did take their lives, here are some of the antecedents, some of the things you'd expect: restriction to education, disruption to home circumstances, isolation in home appeared to be contributing factors. So kids, possibly an increase early on, but no reassuring in some ways, but pleasingly in others, that actually we're not seeing a rise. Obviously, every kind of child suicide death's a tragedy, but we're not seeing a rise subsequently. What about all ages? So this is the real-time findings. So Public Health England are working on a real-time surveillance system across the country. They've just got funding to do that. But this is something we did as part of NCISH that Lewis Appleby led on, where actually we collected data from established real-time systems. So systems that have been going a while, 6 areas with a total population of 9 million. So by no means a comprehensive national sample, but the story there, the blue bars are what I want you to look at here. The story there is there was no discernible rise in suicide around the time of the lockdown, and these bars, going up and down, are in the within the limits of normal or chance variation. The purple line there are the equivalent numbers from 2019. So a restricted number of areas, early data. Things might change subsequently, but no indication of suicide having increased in the short term there. But that, of course, is just the top level of the pyramid. What you've got is the lower levels of the pyramid. So where do people present when they hurt themselves? Well, they present to our emergency departments. Here's data from just 2 emergency departments in Manchester. The green line is what you're looking at here. So basically what you see is a 40% fall in attendances for self-harm at emergency departments. It's come up subsequently, but despite the random variation, it's still probably below levels that it was pre-lockdown. This only goes up to August. So a fall off in help seeking around the time of lockdown, a gradual increase since then. That was Manchester. A similar picture from Oxford and Derby as part of the multi-centre monitoring. And these are people now who have self-harmed and been seen by mental health professionals in general hospitals. So not just emergency department attendances, these are people seen by liaison psychiatry services. The green bars, again, are what you want to be looking at. This time, again, very similar, 30 to 40% fall, 30% in this case, in referrals for self-harm, with an increase afterwards, but still below pre-pandemic levels. The black line here is what has happened in 2019. Where else do people go? They go to their general practitioners, primary care. Purple line here, this is a study of about 14 million individuals carried out by my colleague Sarah Steeg. Purple line, again, similar story. In this case, it's about a 25% fall in primary care, general practice attendances for self-harm. The hatched area there is the average based on previous years. So we've got this fall off in help seeking for self-harm. Is that due to people being frightened to seek help? Is it due to accessibility of services, or is it due to the public health messages we had early on about protecting the NHS? It might be any of those. The other thing, of course, though, to look at is what's happening at the next level down in the pyramid. So what's happening to community levels of self-harm, and you'll have heard us talk about this study before. It's the UCL social survey. There's the link for it. Tens of thousands of people. It's not a population-based sample. It's a, if you like, it's a convenience sample. In some ways, it's people who respond, but still, I think, a really valuable study because they look at things week on week, and this is people reporting self-harm in the previous week. And what you see, basically, we don't have pre and post lockdown data here, we just have post lockdown data, but nothing very much seems to have happened in terms of self-harm increasing or decreasing in most age groups. It's interesting though in the younger stage groups, I think, the recent data in the younger stage groups, because you might say, well, September, October looks a bit lower in terms of self-harm in the younger stage group, and if that's the case, I mean that was the time that universities kind of reopened, but overall no trends in self-harm. So the big story, I think, for self-harm is a reduction in help seeking early on in the pandemic with a, if you like, a gradual increase. But community levels of self-harm were staying the same. So if community levels of self-harm are staying the same, the question is, where were all those people going? Were they seeking help? Were they not seeking help? Well, many of you in touch with colleagues in the third and voluntary sectors will know that many of them are reporting a big increase in calls. The Public Health England surveillance report is worth a look at. That shows quite a variable picture, actually. But it's not just the volume of calls. This is a really interesting bit of research from Samaritans in Ireland, where they showed a slight increase in the number of calls, but actually they showed that call duration, the blue lines there are call duration in lockdown, the red lines are the call duration prior to lockdown, showed that call duration and complexity went up. So that's something worth bearing in mind, both for helplines run by statutory services and for voluntary sector activity. And of course, you know, the findings in the UK aren't unique, and John's colleagues are a systematic review where basically they're checking for new papers being published daily. There's no real evidence for any increase in suicidal self-harm there internationally. The one possible exception is Japan, and that's actually more recently, not during the initial period of lockdown, more recently, so that's worth keeping an eye on. But of course, we know the things that we're concerned about: social isolation, economic concerns, especially going forward. And that was echoed. It's not just the Living Systematic Review. A lot of you will have seen this editorial in the BMJ a couple of weeks ago. Again, we'll include the links in the slides so you can have a closer look if you need to. But in terms of what we all do about suicide prevention, although, you know, the context has changed, the evidence and the activities remain, I think, the same. So for those of us working in mental health services, about trying to ensure access, trying not to kind of exacerbate divides through introducing a digital divide, digital inequalities, which I know a lot of people have been talking about, making sure we've got crisis services that are in place, support for those who are isolated, bereaved. I know Tim's going to be talking about domestic violence and domestic abuse, thinking about community measures, thinking about data, and I've already mentioned partnership with local colleagues and local areas. Thanks very much. That was a very quick whip through the recent data. All the slides will be available. The links on the slide should work. I just want to thank all our staff who continue to put up with my constant demands for urgent information, worked kind of tirelessly through all this, and this will be of historical interest in years to come, you know, how we were and then how we were in 2020, and hopefully we'll get back to the face-to-face soon. Thank you very much.
Thank you very much. Now, as always, that really interesting run through the latest thinking and evidence. I noticed you still don't have your own picture on. There's no picture of you on that last slide. Is everyone else in the team except for you?
It's a bit like what my kids say. The kids there's loads of pictures of the kids, and I'm never in them because I have the excuse with my family that I was taking them. I have no excuse actually for why I'm not on those slides. Maybe we'll revisit them once we're back in the offices. Thanks very much. Can I check? I've stopped sharing my screen because it's You're not seeing my screen on your.
No.
What, that's great.
Yeah, that's right.
No. So we're seeing you now, which is great. So didn't have your photo, we have your video. So we've got a bit of time for questions now. We've just got actually a great question in the chat from Francesco Palmer, who also helpfully updated us on the European nations draw before the meeting, possibly in the wrong chat. But Francesco's got a question, which is, I think, so sorry, I'll contextualize the question as well from my point of view, which is, I've been on quite a few Wave 4 panels for this program over the last couple of weeks, and really in all of them we've talked about, so how does the suicide prevention program now link with a lot of the transformation programs that are happening in mental health, so in particular the community mental health framework and community mental health transformation program, and how that's rolling out. And I suppose it is a different landscape that we're looking at now, and it will change more. A lot of work across the country going to kind of move into communities as part of that transformation program. So Francesca's got a question related to that, and I know, Nav, you at NCISH, you're doing work around self-harm as part of that program as well. Francesca, I wonder if I could just ask you to ask your question, because it's quite an involved question. It might be better coming straight from you.
Hi, Francesca.
Can you hear me?
Yeah.
Can you hear me?
Yeah, we can.
What it is basically is that when I look at the training curriculum, all the universities that are validated to produce future mental health nurses, and look at this CPD training for nurses within mental health trust, I think what they've done is gone a little bit slow in terms of what the NHS long-term plan, which is nearly 2 years old, has actually got in store. Okay, maybe the implementation plan came in the summer of that same year, and then in September the community mental health framework. Now I can only speak as I find in my own STP area, and we've got different commissioners for different work streams. I'm just one person trying to push and ask questions around the personalisation agenda. And one thing that patient and carers constantly say is about having to repeat their story. So I can see the value in moving towards personalised care, where we've got a personalised care and support plan. And the difficulty is that all different trusts and organisations have different computer systems, and they don't all talk to one another. So the ambition to have one set of care records that are digitally produced may not be an aspiration that might be met for some time. But I think what is important is that the ambition for people with mental health long-term conditions for personalised care out of the 2.5 million is that 750,000 up to 2024 should have a personalised care support plan. Well, the staff need to be retrained because, you know, the care programme approach and the care and treatment review are old hat, really. So really there has to be a transition and a changeover, and, you know, people that have recently come, you know, trained, they're unlikely to have come across personalised agenda through the training that they will have had, and certainly staff from 10 years ago that trained. So I guess the question has to be, you know, do we need pioneer site, demonstrator site to see what good personalised care looks like and what the offer is with for those that have been on Section 3, so subsequently Section 117 aftercare, so what personal health budgets might look like. So, yeah, there's a few.
That's a really good kind of question and kind of commentary on everything that's going on. I want to pick up on a few things you said. I mean, the first thing you said that really resonated was people really, service users being really fed up of having to tell their story 10 times to different people. And that's true for mental health, but it's particularly true if someone's in crisis or has hurt themselves or is feeling suicidal. I think that's particularly true. I think, you know, one of the other things that I'm taking from what you're saying is this idea that, you know, we need to be thinking about how we train our mental health professionals, how we get them to think about pathways of care, and that needs to start right at the beginning with nurses and medical professionals and other care professionals curricula. The third thing you say is I think, you know, one of the most important of all, which is thinking about how we implement the ambition in the long-term plan. So how do we implement that? And, you know, there's several elements to that. I think one is thinking about implementation. So we talk about this as part of the self-harm work. So if you're going to implement something, think about an actual formal framework for how you implement it. So Tom and colleagues, you know, are experts in a quality improvement framework. There are other frameworks available. So thinking about the methodology for implementing, I think, is really important. Thinking about measuring what you do is really important. And then, you know, the idea is, well, how do we roll this out? And I think the model that NHS England are adopting, which I think is a really good one, is this idea of vanguard or pilot or champion sites. So, you know, it's about getting enthused early adopters to do stuff really well, and both in terms of, you know, the suicide prevention program, the self-harm program, you know, the other programs, you know, using the learning from people that have done it really well, and then kind of allowing that to diffuse. So I don't think this is easy. I think this is really kind of ambitious, but it's an exciting time to be in mental health. It really is.
Thank you both. Great question, and thank you, Nav, for your thoughts. Kath, you've just talked about some work that you're doing on risk assessment, and actually, Kath, I'll come to you in a second, because I think, Nav, there's a bit of the question that I think maybe people want to hear a bit more about, which was about where risk assessment might fit within personalised care plans.
Yeah, I think, you know, we aren't in mental health, in social care, going to get away from this idea with risk assessment. It's something that's there, but we have to think very carefully about what it's for. And what I think, and what colleagues here think, is it's not for trying to predict what's going to happen in that individual. It's not the basis on which we must allocate care. And instead, we need to think quite carefully about what the process of risk assessment should be. So it's not a risk assessment for us as professionals or for our organisation. It's an assessment that does need to be individualised. It needs to be focused on the needs of the service user in front of us. And it needs to be, if you like, linked directly into a management plan. So, you know, it's part and parcel of what we do, but we do need to think, I think, quite carefully about what risk assessment's for, because it's almost been co-opted to mean things I think that it shouldn't. And I'd encourage you to click on the link to the paper, have a listen to the podcast, and on our website we've also got the kind of risk assessment report. So Leah Quinn-Liven, who's another close colleague that works on me and works with me in the patient safety centre, so another different bit of our university, has done loads of work on risk assessment. So we're happy to share that with people. Yeah,
I wonder if perhaps Nick would be able to put a link to the paper in the chat. I know it was on your slides as well, but just for people to go straight to. Kath,
Nick, I'm hoping you're there and can do that.
I think Nick is there, so I hope so, and I know she can do it. Kath, I don't know if you want. That sounds really interesting. The research, the work you've been doing there, that you've got research running for, and if you can tell us any more about that.
Briefly, yeah, but it was based on Nav and NCISH's work around risk assessment and drivers from people with lived experience in our area that lost people. One lady in particular lost her daughter that was really focused on developing safety plans and needing to develop the evidence based around personalised safety plans. And obviously, as a clinician myself, having worked with risk assessment for years, so we used the NCISH research and work to inform the plan to develop with people with lived experience exactly what Francesca's saying, a model where we're building how do we work with practitioners to develop a personalised approach to safety planning that isn't based on a tick box approach to safety planning. So I think we're really excited about that work, and hopefully that will have contribute to the evidence base.
Yeah, I think that's a really important point, Kath. We changed our name, so we used to be the Centre for Mental Health and Risk. Now we're safety, and moving the conversation away from risk and towards safety, I think is really helpful. And of course, safety plans, there's not a huge amount of evidence base for them. They're in widespread use, and personally, I think they're really good. But it's about also one of the things we talk about locally. It's the how of. It's how they're used, not just the content of what's in them. They need to be collaborative, and then they can work really well.
Yeah,
that's great. Thank you.